Certainly at this point, we don't have great biomarkers for response, but we have some markers that we use to help us direct certain types of therapy right now, but we definitely see different data in different diseases. Ideally, a great biomarker would say that if you have that biomarker, whatever it is, that you have a 100% chance of responding or benefiting from this type of therapy. But I can tell you, we don't have a great biomarker for this. Certainly even for, like, say, lung cancer or with EGFR mutations, or in melanoma, BRAF mutations, where the chance of responding is well above 50% chance to drugs that target that mutation, we are not there yet for immunotherapy, no matter what biomarker you have use or patient selection criteria you use, but we're working on it. And that's where we truly need your help, and we really thank the patients who are part of this type of work to help try to figure out why someone does really well for a long period of time, or why another patient does not respond at all. And we're looking at markers in the blood as well as in the actual cancer itself. So sorry, these are very wordy slides. So we're going to look at and talk about PD-L1 expression. Really, that's the biomarker that's been studied the most so far. And we're excited about it, but on the flip side, we're also disappointed. PD-L1 expression, we're looking on tumor cells, is correlated with improved survival when treated with PD-L1 checkpoint blockade, except in the case of Nivolumab and squamous lung cancer. So it does depend on the tumor. Some tumors, it is equated to improved survival, and other tumors it's not. I'll show you some data where it is not associated with improved survival in kidney cancer. PD-L1 expression tumor testing is required for Pembrolizumab treatment in non-small cell lung cancer. Then PD-L1 expression may help guide combination immunotherapy in melanoma patients, and some of that data was presented earlier this day by Dr. Walchuk at SITC. And PD-L1 expression is not correlated with benefit for kidney cancer patients, and I'll show you that data. And then multiple questions remain about PD-L1 staining, and we'll go over the pitfalls of having tumor tests being tested for PD-L1. And so when you get a test back and somebody tells you that your tumor is PD-L1 negative or positive, you need to know what antibody is used, what cutoff was used to give a positive result, and did they have enough tissue to do this. And then lastly, I'll talk about something more experimental and talk about mutational burden, which may predict clinical benefit, but it's not ready for prime time. So what is PD-L1 testing? What exactly is it? This is a test that's run on a cancer biopsy in a pathology lab. The test stains for PD-L1, which is the ligand, which is a protein. The ligand is ligand to the PD-1 receptor, and that ligand is on the bottom. So PD-L1 is expressed on tumor cells as well as other cells, and then that binds to the PD-1, and so that's what we're talking about and looking for. So tumor PD-L1 expression, just so you know, this is what we're learning. It can be expressed on tumor and various immune cells. So PD-L1 can also be expressed on B cells and other cells within a tumor. So a tumor is just not, a biopsy is not just made up of cancer cells, it's also made up of cells that infiltrate the cancer, which sometimes can be different immune cells. They can also be something called fibroblasts that help support the structure of that tumor or cancer, and then it can also be blood vessels as well. PD-L1 staining can be variable within a tumor, so if you look at a tumor as a whole, typically we see the most concentration, if your cancer has this within it, it's concentrated on the tumor edge, but it can be patchy. So you can biopsy multiple areas, and some areas will be positive and some areas will be negative. PD-L1 expression can change over time, and it's dynamic. So some types of therapies actually are known to increase PD-L1 expression. Some are known to decrease PD-L1 expression. Early stage may have different expression than in patients who have metastatic disease, so it's really dynamic. We know that radiation can upregulate PD-L1 as well. PD-L1 is actually measured as a continuous variable. When you get the results, it will say positive or negative. Well, what does that mean? We look at a tumor and look at a snapshot of the tumor, and we look at what percentage of cells that slide has that are PD-L1 positive on the cell surface. And so it can be 0%, 1, 2, 3, 23, 25, 50. So it's a continuous variable up to 100%. And we artificially say something's positive or negative based on some data that we'll go through. So it's very important, what does positive mean? Because really it's a continuous variable. So, and I think it's important to know, and we don't yet know the details, which PD-L1 antibody that is being used to test your cancer. Should we use it to stain your cancer? Each drug that's being developed in this space, and this is not an exhaustive list, has an antibody test that's being developed and coupled with it. Each test has its own biopsy. They have not compared these antibody tests amongst themselves yet, but various different groups are trying to do that and pushing to do that to try to figure out which test is the best to use and how do they compare. Does it make a difference if you use the antibody the 28-8 antibody that was developed with Nivolumab, or say the Atezolizumab antibody to test the tumor SP142? Also, the question is, what cells should you measure? We think for sure that it's important to measure tumor cell expression of PD-L1, but what about the immune cells in there? A lot of people have looked at, do we need to look at tumor cells, just the immune cells, or both? And depending on the group that's looked at this, depends on where they're placing their bets. The Atezolizumab group is looking both at tumor and immune cells. And then also the definition of positive. Right now for lung cancer, this is the only area where an antibody is coupled with a test in order to actually receive it. For Pembrolizumab in lung cancer, you have to have 50% of the cells on that tumor test express PD-L1, and that's the only way you technically you can get Pembrolizumab if you have lung cancer. Where other tumors right now, this is not required to receive one of these antibodies, and I'll show you some of the reasons why that is. Some companies are using a cutoff of 25% to get onto a clinical trial. Other companies are going much lower at 5%. So it really, no one knows exactly what the best cutoff is. And the technology and the data have not caught up to where we are with each antibody. So I think it's very important to know when you get a test back, what does that mean? Does it mean that it's positive, that they're using a 50% cutoff, or is it negative because it's only 1%? So in general issues like we've been talking about, so it's very important that you have a large biopsy to get a better picture of what that tumor is. It is not sufficient to get something called an FNA, a fine needle aspirate. That's where they put a small needle in, they suck out the cells. That's what radiologists and pulmonologists and others like to do because it's less invasive, less risky, and it can get you an answer. But it does not give you enough tumor tissue to do mutation testing, and definitely does not give you enough cancer cells to do PD-L1 testing on. So at least a core biopsy is needed. Certainly we have to address heterogeneity. Multiple tumors, does it make a difference if you biopsy the metastasis, like if you have a bone metastasis, or the primary tumor, say if the primary is in the kidney? We just don't know what are the differences depending on where you biopsy. Also, we think it's important about the interval between biopsy and treatment and the effect of other therapies. So if you had a surgery, say a kidney removal 5 years ago, and now you have metastatic disease elsewhere, can we test the original tumor that you had? Does that give us a better snapshot? Or most of us feel that you need a new biopsy if we're gonna be looking at PD-L1 testing. Again, knowing which antibody is used is helpful right now. And then using what is the cutoff is very important. And none of that truly, I don't think, has been worked out except for Pembrolizumab for lung cancer. So, I'm going to go through each different tumor. First, we're going to start with lung cancer. Sorry, those with other tumors. We'll go through melanoma data as well as the recent kidney cancer data. And then we'll kind of wrap things up. So for lung cancer, PD-L1 expression on tumor cells is correlated with improved survival, except in the case of Nivolumab when in squamous cell lung cancer patients. And PD-L1 expression tumor testing is required to be treated with Pembrolizumab if you have lung cancer. So, and this is all the data. I'm not going to go through all of this data. Except to show probably this. This is the data that was used to get Pembrolizumab approved for use for lung cancer. And just to show you, in lung cancer, if you look at different levels of expression, so the far left side is negative expression, so no cells actually were seen to have PD-L1 on the tumor. So, and that's actually the majority of the patient. If you look at the dark blue line, about 40% of patients on this trial had negative tumor testing. In contrast, less common, if you have 50% or 75% or higher, that was less common to have. But as you can see here in the pale blue lines, if you have PD-L1 native tumor, the response rate, well, it's not 0, you can still respond. The response rate is about 1 in 10. But if your tumor is very highly expressing the PD-L1 expression, then that response rate is much higher, close to 50%. Okay, but it is not higher than that. It's not like 100%. But it just stacks the deck better or higher in the fact that if you have more PD-L1 expression with this test and then treated with this antibody, Pembrolizumab, with lung cancer, you have a higher chance of response compared to if your tumor is PD-L1 negative. So, and then also, this is the squamous cell lung cancer data. Again, ignore all of the numbers on this side. But using the graph on this far right-hand side, black is PD-L1 positive tumors, red is PD-L1 negative tumors. For patients with squamous cell lung cancer, if you test their tumors for PD-L1 antibody that was developed with Nivolumab, it does not matter in this group of patients whether or not your tumor stains positive or negative. You can benefit no matter what, and that's this data. So, and this is looking in non-squamous, so looking at a same lung cancer but a different histology. In this group of patients, they're more likely to benefit from Nivolumab if their tumors are PD-L1 positive, and using various different cutoffs at 1%, 5%, and 10%, it does not seem to make a difference. But if you're PD-L1 negative, you're less likely to respond and have equal survival compared to chemotherapy. So again, we're seeing a lot of mixed data in lung cancer. Now in kidney cancer, they have, early on, the thought was that PD-L1 expression did help predict survival just in general. But in this study that was recently actually published yesterday in the New England Journal, PD-L1 expression in kidney cancer or renal cell cancer, it is not associated with benefit with Nivolumab. And again, you have to take the survival curves somewhat in a grain of salt. But if the one far side is positive patients with positive tumors, the right-hand side is patient with negative tumors, and your cancer, if you were treated with Nivolumab, whether or not your cancer was positive or negative, you did better compared to if you were treated with Everolimus. So that's hopefully will be the basis to get Nivolumab approved for renal cell cancer patients. So in kidney cancer right now, renal cell cancer, we do not recommend PD-L1 testing right now. What about in melanoma? We know that in melanoma, the chance of your tumor being positive is much higher compared to other cancers. Typically, they say it's anywhere between 50 to 80% of patients with melanoma, their tumors are positive, where lung cancer, being positive is about maybe at most 50%. It's much more common in melanoma. And based on some of the data that was presented this morning, as well as at ASCO this year, PD-L1 expression may help guide combination immunotherapy with melanoma in melanoma patients. And we'll show you this data here. So Dr. Walchuk and colleagues presented this data that if you had a PD-L1 positive tumor, there was no difference if you received nivolumab or nivolumab plus ipilimumab. So maybe in those patients with PD-L1 positive tumors, you could do just as well with nivolumab compared to the combination. We know combination therapy does have higher chance of side effects, so at least in melanoma patients, maybe you can just get away with nivolumab. But in those groups of patients with PD-L1 negative, you actually did better with the combination compared to nivolumab. So again, right now, it's not in melanoma, it's not helping us to decide should you receive either pembrolizumab or nivolumab by itself, but maybe if you have PD-L1 positive tumor, I'd be more likely to give single agent nivolumab or pembrolizumab compared to if you had a PD-L1 negative tumor, maybe I'd be more likely to push the side effects and give a combination therapy. Talking with Dr. Walchuk this morning in the session, right now they're not testing, but again, in certain patients when they're trying to decide, should we push the side effects or not, or push the response rate because the response with combination is quite high, maybe in the future he'll be testing this based on this data. And here for this trial, PD-L1 positivity was defined as having at least 5% of cells, 5 out of 100 cells, staining positive for PD-L1. So what do you need to know about this, okay? One, do you have enough tissue to do the test? It can't be done on a fine needle aspirate. Two, if you have a PD-L1 test run, which antibody is being used? And what is the definition of positive? I think that last point, what does the definition of positive really mean? So what's the percentage of cells? And right now, the only test required to receive a PD-1 antibody is in lung cancer whose doctor wants to use pembrolizumab. Otherwise, PD-L1 testing is not required for patients who are receiving nivolumab or even the combination, and the same with patients with squamous cell lung cancer. PD-L1 staining may be helpful to predict the outcome or chance of benefit or help weigh the pros and cons of receiving PD-1 antibody treatment or the combination, but there is no test that will accurately predict whether the treatment will work in you right now. It may, again, stack the deck and make it more likely, but it's not going to say 100% that this is going to work in you, but that's what we're working towards. And then lastly, this is a rapidly changing field. A lot of focus is being made on this type of therapy because we want to be able to individualize this type of therapy for you. And again, stay tuned. And again, this is probably the hardest field to stay up to date on, and that's why we're all here to try to learn more and try to advance the field. What about tumor mutation burden? We know that there are mutations that make abnormal proteins that your immune system might be able to recognize as abnormal. So that's how we think that sometimes the immune system can surveil your body and figure out what are those abnormal cells. There are not mutations. These are not mutations that you can pass down to your kids, though, okay? This is a very experimental field and not ready for prime time, so don't go out and ask your doctor to do whole exome sequencing right now. But please participate and consider allowing us to evaluate your tumor if you're going on immunotherapy, and so there's a lot of trials. So this is based on some of the data. This is looking at all cancers, okay, and looking at mutation burden. And as you can see here, those cancers right now that we know are responding to PD-1 or PD-L1 antibodies are on this far right side. Melanoma is one of the tumors that has the highest mutation burden, okay? That's one of the reasons why we think immunotherapy works so well in patients with melanoma. Lung cancer is the next highest, that has the highest mutation burden, but there's a wide variety. Bladder cancer has a high mutation burden. Head and neck cancer, Renal cell cancer is kind of in the middle, so we're not quite sure in patients with renal cell cancer about how does mutation burden predict, but maybe it might be. And so we're trying to look and see. I think some of the data that came out really making us interested in looking at this is Dr. Rizvi and colleagues up at Memorial, and now he's at Columbia, looked at lung cancer and looked at the mutational burden. And this is, they are looking at mutations that actually make abnormal proteins, because you can have a lot of mutations that don't make any proteins. They're just there and they don't do anything. But they're specifically looking at mutations that make abnormal proteins, and that's what is called non-synonymous. So the higher the non-synonymous mutation burden, the better the benefit to at least this antibody, Pembrolizumab. And so we're looking to see in larger groups of patients whether or not this is true. Also, following up on that, recent data that was presented at ASCO and now here at SITC by some of my colleagues from Johns Hopkins. Back in the first Nivolumab trial, we had one patient with colon cancer that responded to Nivolumab. And then from then on, we saw no patients with colon cancer respond. They went back and looked at that patient, and that patient had an abnormality called microsatellite instability. This, what's called MSI, is actually associated, those tumors have a high amount of mutations in their cancers compared to the average patient with colon cancer. And this is called mismatch repair deficient tumors. And so they're not able to repair the mutations that occur over time, and so mutations start building up and building up and building up. And they saw that in a group of patients treated with Pembrolizumab with those particular tumors, that a very high chance, a high response to Pembrolizumab or drugs like this compared to patients with colon cancers who did not have that mismatch repair. And so this data lends the support to the notion that mutation burden is associated with clinical benefit with these types of drugs, at least in potentially lung cancer, potentially colon cancer if you have this MSI abnormality, and other cancers such as endometrial cancer, that some of these tumors can have this MSI abnormality. So again, this is helping us advance the field. Interestingly, I can just tell you an anecdote. This trial almost never happened. Out of the altruism of a group called Swim Across America, they donated money to actually run this trial, and the company did give the drug for free, and they were able to run this trial, and now we're seeing these results. So without altruism from groups such as Swim Across America and others, this trial would never have been able to happen, and we'd never know. So in summary, PD-L1 expression on tumor cells is correlated with improved survival when treated with PD-1 checkpoint and blockade, except for the case of Nivolumab and Squamous. PD-L1 expression tumor testing is required for patients receiving Pembrolizumab in non-small cell lung cancer. PD-L1 expression is not correlated with benefit to this type of therapy in patients with renal cell cancer, so right now I would not recommend PD-L1 testing in this patient population. PD-L1 expression might guide those patients who should receive combination therapy or not in melanoma, but multiple questions remain. So it's not an absolute thing that you absolutely need your tumor tested for PD-L1, because there is so much that can cause a test to be negative. Just in the fact we need to know what antibody is used, how sensitive it is, what is the cutoff being used, and where was the biopsy done. And I think potentially in the future, mutation burden might be some of the answer for some of our patients, but it's not ready for prime time. Thank you.